Jennie Jacques interviews Professor Jack Lambert, Part 2. In my 7th year with ME, I want to remain as informative as possible as to what I am doing to further investigate my own situation, just in case it can help anyone else with their Rubik's Cube of an illness.
We were here today to discuss the results of the Armin tests, right? Because that was the purpose of, or part of the purpose of being on the call today, right?
Yeah, I just wanted to make a part 2 of our last interview. I really want to make this as easy as possible for anyone else who wants to do the same.
1. Contact Professor Jack Lambert. Visit www.iddoctor.eu. Here you can make an inquiry, make an appointment, and learn more about treatments and pricing. 2. Decide if you want to test via Armin Labs like I did. www.arminlabs.com. They introduced me to the Academy of Nutritional Medicine, AONM.org, and bloodsandbeyond.co.uk introduced me to my nearest mobile phlebotomist.
The way I usually run a consultation is I don't really start by discussing the Armin Labs. I just kind of try to go back through your history a little bit. Testing is supportive of your diagnosis, but it doesn't prove your diagnosis. What I'd like to do is just actually go back through, your history a little bit, just in terms of your signs and symptoms, and then we can kind of discuss the lab results. When was the first things started going wrong with you? When was that?
At the end of 2018, I got really sick with what I thought was the flu.
Where were you located geographically?
We were on a hiatus from the acting job, so I'd just flown to New York with my partner, and I was really, really unwell while I was there. And then I came back, and in January I was hospitalized twice with an acute severe viral infection that was EBV, the Epstein-Barr virus, complicated by severe viral hepatitis and chronic UTIs that I just couldn't shift as before the viral infection, and a kidney stone that was sort of accidentally found in a CT scan. And they gave me an emergency neck biopsy to rule out lymphoma.
Right. And then you told me that they did PCRs on your blood, and your Epstein-Barr virus stayed positive for a long period of time. Is that correct? What I recall?
My infectious diseases doctor said that she'd never seen it for that long stay so high, so she kept me under her care, even when I was sent off to the chronic fatigue, whatever they call it, where they at the time gave graded exercise therapy and CBT. But yeah, I still had the viral load in my blood on the PCR, which was just really strange. She kept me under her care, but she said there's nothing she can do to help that. She just wanted to keep measuring it. So that's what we did. Being unable to clear the viral load from my blood for so long is unusual, and I was diagnosed with EBV viremia, which ultimately helped me gain credibility with doctors. But my experience overall is not unique. Millions of individuals worldwide fall within the 10 to 12% of people who are unable to fully recover from infection. This is old news. Until 2021, our NHS guidelines encouraged exercise as part of treatment for ME, despite evidence that it worsens symptoms and in some cases permanently disabled individuals. I want to stay responsive to the new and push forward with the science we have to date. But if governments, healthcare systems and institutions had just listened to the concerns of the ME community rather than dismissing or further stigmatizing them, long COVID would not have emerged as the widespread issue it has become today.
Energy, you're functioning at what, 10%? I mean, compared to the way you were before?
At about 10 to 20% at the very most.
And concentration, brain, is that cognitive function? Has that been a problem?
Yes, it is a problem. I've even got results from when I did hyperbaric oxygen before and after, showing how significantly reduced my cognitive ability is/was.
Okay. And then headaches, head pressures, yes, no?
More so in my neck. I always had this odd theory that I felt like the virus was in the base of my brain or my neck. Not headaches so much. I occasionally will get them, but thankfully I don't suffer severely from migraines, but I do get them intermittently.
Right. Pains anywhere else in your body?
So all over my body, it's like a dull ache, and in my joints, some days are worse than others. If I overdo it, it will be worse. Like I've constantly got a low grade fever or flu, even on my better days.
Numbness and tingling? Any part
I
of the body?
occasionally get numbness and tingling in my finger.
Professor Jack Lambert thoroughly reviewed my medical history to better understand my condition, and I will provide more context, but I'm going to edit it because I want to be able to focus on the Armin Lab results, my lovely bladder, and of course our next steps. ME has no cure, and recovery is rare. If a treatment works for me, it may not work for others, due to the many variables at play, including genetics, disease progression, individual responses, environmental. Look, the list goes on. I believe transparency is key, not just to raise awareness, but to help others understand ME. This is a neuroimmunometabolic disease, and it can be very isolating. If sharing my experience helps just one person feel less alone, it's worth it. I believe persistent infection and immune dysfunction are central to my issues with ME, though I continue to explore other possible causes. One I'll be exploring soon, for example, is poor pelvic venous return, and that refers to a condition where blood is not draining effectively from the pelvic region back to the heart. Another interest of mine is that the research we have suggests people with myalgic encephalomyelitis may experience disruptions in their fat metabolism, with evidence pointing towards altered fatty acid utilization and potential issues with lipid droplet function, potentially contributing to the symptoms of the disease. The exact mechanisms are still being investigated, and further research is needed to fully understand the complex relationship between fat metabolism and ME/CFS. However, for now, I'm focusing on the research that suggests chronic infections, viral or bacterial, can trigger or worsen this disease, and immune dysregulation may explain the ongoing symptoms many of us experience.
Heart going too fast, heart going too slow.
POTS and dysautonomia symptoms. For example, today I took ivabradine, which slowed my heart down, and I did my mascara stood up, which was quite nice. But the reason I'm lying down now in this interview with you is because sat up, it just takes too much out of me.
Sleep disturbances or sleep's good?
It's mostly disturbed by going to the toilet and an inability to get to sleep a lot at night time.
Okay, and then mood, more anxious, more nervous, more sensitive, noise, sound, light, anything like that? Oh.
Noise, definitely. Light, yes, sometimes, but not always. On a bad day, I'll have the curtains closed and my eye mask on.
Did you have bladder problems pre-existing 2019? Chronic urinary tract infections, or what was the issue?
I've always had an issue with my bladder that's got worse over time. That has always been a weak spot.
For over 10 years, I've battled persistent bladder pain and recurrent flare-ups, treated with countless antibiotics, yet nothing provided lasting relief. NHS tests repeatedly failed to detect an infection, despite ongoing symptoms. The power of DNA sequencing. Standard urine tests miss up to 90% of bacteria found in chronic UTIs. Private DNA sequencing finally identified a high bacterial load, proving that conventional testing wasn't fit for diagnosing my complex case.
Did your symptoms improve when you took the antibiotics?
The pain in my bladder is less, but I still have to sleep with a hot water bottle on my bladder, or go to bed every night with a hot water bottle to bring some relief, because it's definitely still there, so it's sore.
For some people, targeted antibiotics after DNA sequencing can resolve the infection, but for me, pain persisted. When a severe flare-up hit again while editing this footage, I analysed my past test results and noticed a pattern of biofilm-associated bacteria that seemed to shift rather than clear after treatment. I had actually already started Dr. Jack Lambert's protocol for a bacterial infection found in my blood. My hypothesis? The azithromycin he prescribed likely disrupted biofilms in my bladder. But it wasn't enough to fully eliminate the infection. With supportive private test results and an understanding of how biofilm infections can behave, we strategically introduced the following specific antibiotics for my case: amoxiclav and metronidazole. Both penetrate deep into bladder tissue and biofilms to target bacteria that may have evaded past treatments. Biofilm disruptors, helping antibiotics reach bacteria embedded in biofilm layers. If this approach isn't the final answer, the next step will be specialized biofilm testing to uncover or rule out deeper hidden infections, and further investigation into blood flow issues, notably pelvic venous return dysfunction, in case my persistent bladder symptoms are indeed non-infectious and non-immune. More on this topic soon. This journey is complex and ever-evolving. I share my experience with hope to help others facing the same struggles or similar feel less isolated. If you're dealing with symptoms of unresolved UTIs, DNA sequencing, biofilm-targeted approaches, and further investigation into pelvic venous return dysfunction may be worth exploring.
What tablets are you taking every day, or supplements, or whatever else?
That is a really long list that I'd probably be better off emailing to you.
Just email that to me then, if you would. Tick-borne infections. Ever been exposed to ticks? Ever had a tick bite? Ever been in a place where you could have got a tick bite?
Potentially, yes. The Ellis spot came back clear, obviously, from the Armin Labs, but potentially, yes.
Let's just move on to the Armin Labs then. I just wanted to just go over everything,
This is a Rubik's Cube of an illness. My Armin Lab results showed EBV, the Epstein-Barr virus reactivation, highly positive at 93. That's significant chronic immune activation from this particular virus. There was some level of chronic stress from cytomegalovirus, CMV, an active infection, high mycoplasma pneumoniae, and a recent Coxsackie virus infection with positive IgG-IgA. But the thing that stood out to me was the low CD57 and NK cells, suggesting chronic immune suppression. If your immune system is not working properly, it won't always recognize the infections to enable a blood test to show that you are indeed positive. Although my blood results clearly point out several things are wrong, there could be something else hiding. I want to know who is at the front seat driving this absolute train wreck in my body.
Can you attribute all your symptoms to Epstein-Barr, or is there something else on top of Epstein-Barr virus that might be contributing to your symptoms? That's really the question you have, and that's the question that the Armin Labs are trying to answer. Fact is, your lymphocytes are a bit low, so that's just one thing to observe. He did the Ellie spots. If it's positive, it's helpful. If it's negative, it doesn't rule it out, because it depends upon your immune system. And if your immune system isn't working well, you don't generate a good response, even if you have an infection in your body. So the tests are positive. You have an Ellie spot that's positive for mycoplasma. Mycoplasma is a bacteria that goes into cells, goes intracellular, and can cause chronic consistent problems. Your CMV Ellie spot was positive low level. Your Epstein-Barr virus was positive at a higher level. And then I think you also had Coxsackie virus. So the bacteria that we're identifying is the mycoplasma infection. Is this all just Epstein-Barr virus and your immune system not being able to control it? Or is there a contribution from mycoplasma pneumonia? The answer is we don't know. This is your immunological memory. For sure, you've been exposed to Epstein-Barr virus, you've been exposed to CMV, you've been exposed to Coxsackie, you've been exposed to mycoplasma. You could have been exposed to some of these other infections as well, and your immune system just isn't generating an immune response, either an antibody response or an Ellie spot. There's two parts of the immune system. There's antibody-mediated and there's cell-mediated. So the Ellie spot kind of measures cell-mediated immunological responses, and the antibodies generate antibody responses, B cells and T cells. Those are the two different types of immune cells. B cells is antibody, T cells is lymphocytes, cell-mediated. So at this point, when I say to patients, I say, well, there's a possibility that mycoplasma could be playing a role. There's no magic way of proving it. We can't biopsy your brain. We can't biopsy your tissues. My suggestion is you go on a trial of antibiotics targeting mycoplasma. And the trouble with mycoplasma mycoplasma, it goes intracellular, it goes into the cells. So you need to go on antibiotics that get into the tissues, deep into the tissues. So things like doxycycline don't penetrate as well into tissues. People think that what that does is it drives the bacteria into the cells, into the tissues, but doesn't eradicate. And I tend to add in antibiotics that get good intracellular penetration. If that bacteria is in your brain and your tissues and your heart, in your muscles, in your joint, in your bladder, the only way to test that hypothesis is go on a trial of antibiotics. But it's not just the antibiotics that get people better, it's the immune system and the inflammation that's generated as a part of that. So I tend to put people on a combination of supplements and low dose naltrexone. And you've tried LDN in the past, is that correct?
I have been on LDN before, but not while targeting specific bacteria with long-term antibiotics and various supplements like the ones prescribed from just herbs. So I'm really excited about this approach.
Unfortunately, there isn't any good antiviral for EBV. This is the challenge. The only antivirals you can really get are antivirals like Valtrex. If you use a high enough dose, like 1,000 milligrams a day, or even sometimes 2,000 milligrams a day, you get levels that are higher. It hits the herpes viruses, it hits the chickenpox, the shingles virus, it hits some other herpes virus like HHV6, HHV8, but it really doesn't touch either CMV or Epstein-Barr virus, and that really is a challenge. But I often put people on an antiviral because there may be a contribution of some of the other herpes viruses to this. The best way to target Epstein-Barr virus is to try to repair the immune system, to get the virus back into check. For example, like if you're a transplant patient and you're on transplant medications, to keep you from rejecting your liver, if you take too much transplant medicine, sometimes Epstein-Barr virus reactivate. You can get a hepatitis, you can get fatigue, you get Epstein-Barr virus PCR positive in your blood. And what do the transplant doctors do? They just decrease the transplant medicine so that you're less immunocompromised, so that you won't reject your liver or kidney, but the Epstein-Barr virus will go back into its cage. My suggestion is to go on Valtrex, a high dose, which will suppress most of the herpes virus, but not Epstein-Barr virus. Go on the LDN, go on some of the supplements, and then I would somewhere down the way go on a trial of combination antibiotics. I usually put people on 3 different antibiotics. Make sure you take lots of probiotics, kefir, kombucha, those kind of things, and give it a try, not just for 2 weeks, but for 2 months. Before you even did that, I would start on the LDN, I'd start on some of the supplements, I'd start building up the immune system, because my hypothesis is 3 things going on: infection, damaged immune system, inflammation, and you have to target all 3 at one time.
Always feeling like I'm fighting an infection but not getting over it, if that makes sense.
No, I understand that, and I agree. A low CD57 is a red flag that something's there, but since it's an immunological test, it doesn't say specifically it's this bacteria or this virus, but it's just an indirect measure that something's not right. The issue is, I don't like to prescribe without seeing somebody, without doing some examination, and without doing some bloods. I can send you the LDN, I can send you some of the supplements and this and that, but if I'm going to be prescribing you kind of heavy-duty antibiotics and take responsibility for that, I'd like to just have a face-to-face visit for a few minutes, my own set of blood tests, then we're home free. You've tried hyperbaric oxygen, you've tried some supplements, you've tried this, you've tried that, you've tried the LDN. My approach is trying them all together. Dealing with the infection, dealing with the immune system, dealing with the inflammation, all 3 at one time. And it's quite a safe thing to do. We published this. Only 2 out of 301 couldn't tolerate it from a gut problem, but most people can tolerate everything pretty well. I'm quite happy to, based on today's conversation, to send you out what to get started with plans for me to come over in the next month, just on a day trip, just a half-hour consultation.
That sounds absolutely incredible. I definitely would like to proceed. And in regards to me tolerating certain things, my quality of life, my concern is that it could get lower because it's been lower before. And when I did do other antibiotics, it did reduce relatively significantly. I suppose I just need to be as mindful as possible and keep you informed as to how I'm actually feeling while we try it.
Sure, absolutely. And people sometimes struggle with the antibiotics, but a lot of people just fly through them. So if you do all the right things in terms of preparing the gut, The reason I put people on 3 different antibiotics is usually it's polymicrobial. There's multiple infections involved. And we're learning that from COVID, long COVID. People are getting COVID. Their immune system is going into their boots and they're getting reactivation of Epstein-Barr virus, chickenpox virus, herpes virus, CMV virus, and Bartonella, Lyme, some other bacterial infections are reactivating in the setting of COVID-induced immunosuppression. And you get low CD57s with that as well. So I do think that model makes sense. But unfortunately, testing is imperfect. The thing that proves it is a trial of treatment. And I think that's the next step.
Bacteria are pretty crafty and they don't want to be found, so they hide under biofilms. These biofilms act like a shield, making it tough for antibiotics to break through and do their job. I asked Professor Jack Lambert about supplements that could help mess with those biofilms, and I'm taking a few from this list. Here's what he had to say.
Azithromycin is one of the best antibiotics for penetrating into cells, for getting into biofilm. Rifampicin, which is one of the antibiotics I also use, penetrates into every tissue of the body. So you're already taking antibiotics that are good biofilm busters. So no harm in taking nattokinase, but the issue is you're already taking antibiotics that penetrate and get intracellular. And that's the problem with these organisms and I think that's why short course antibiotics don't work, because you just knock the infection down, but you don't eradicate the infection.
This all makes a lot of sense, and thank you sincerely for your time.
Take care. Bye, Dave.
Bye. I'm not fussy with blood, so it doesn't really...
You okay?
Yeah, I'm fine. I'd quite like to learn to do it myself, actually. Well, it'd save me a trip to the doctors, which exhausts me more.
So if you don't mind me taking a look at your arms, okay? Right.
That's...
That one on.
Do you want me to take this?
No, it's fine. Just give me a second. You're not going to pass out me, you okay?
Oh, no, I'm fine.
Some people are not going to don't move.
Testing is supportive of your diagnosis, but it doesn't prove your diagnosis.
Professor Jack Lambert's words really resonated with me. As someone with ME, it's frustrating, to say the fucking least, when standard tests come back normal, despite debilitating symptoms like post-exertional malaise, PEM. Recently, the results from Armin Labs provided valuable insight into what's going wrong, highlighting issues that traditional tests missed. But these results don't change the bigger issue. If my immune system isn't recognizing certain infections properly, they won't show up in bloods. And that's why it's so important for doctors to listen to patients, especially with conditions like ME, where the science is still catching up. Clinical judgment, experience, empathy, and common sense are crucial.